That was awesome of them to set me up like that. Which one do I push? Okay. Well, these are my disclosures. I don't really have any except for I do all the procedures and a lot of revisions of both. So this was the question, and I put in red the things that you really needed to look at. One of the things that he didn't talk about was Barrett's esophagus in this patient. And what we don't know about this patient is what was her Demeester score? Did she have dysphagia? What did her manometry look like? Did she have short segment Barrett's? Did she have long segment Barrett's? So what does the research say? The real research, not the pretend one. And so when we look at the BOSS trial in 2018, the 5-year data was pretty good. And it looked at, in sleeve, we saw de novo GERD in 31% of people, and much less in bypass. Worse in reflux, again, in 31%, and remission of reflux in only 25% of sleeve patients. Gastric bypass, 60%. And then the conversion rate from sleeve to bypass was 9%. Other research, more research. This was with 30 patients who had sleeves and 16 who had bypass. And they looked at preoperative assessment, looking at pH probe, manometry, and then post-op. And what they found was the Demeester score changed in sleep patients. Not a little bit, a lot. And so it was significant for the sleep patients, but not for the bypass patients. What else? Another study, much like the last one. And so this was 75 patients. They looked at reflux, EGD, Demeester scores, upper GI. 1 year afterwards, GERD was seen in 74% of sleep patients, but only 25% in the bypass. There were independent predictors in sleeve, age, and preoperative esophagitis. So this study kind of was the whole table showing this. And if you look at it, again, the Demeester score changed in the sleep patients, but not in the bypass patients as much. It was statistically significant. The GERD also changed with 26%, or 74%, pardon me, I'm saying it wrong, 26% GERD in the sleep patients. And if you look at Barrett's, this is the thing that we're all concerned about with sleep patients, is that in that study they showed 17% Barrett's in the post-op sleep patients. They also saw that the reflux type of material in those sleep patients was more of a biliary type reflux, which is worse in Barrett's. There was increased erosive esophagitis, and really when you looked at symptoms, there really wasn't good correlation between symptoms and grade C and D esophagitis. So let's go to the experts. So this was from the Sleeve Consensus Conference, the 5th International, the last one that was had. And they looked at the experts' consensus. Those were people who had done more than 1,000 cases, and 80% of the experts felt that Barrett's was an absolute contraindication for the surgery of sleeve. So surgical endoscopy in 2020 looked at sleeve versus gastric bypass patients. And in those patients, esophagitis decreased in gastric bypass by a significant percentage, but in sleeve it increased from 7 to 30%. So there was a modified Delphi consensus statement. 32 countries looked at that. And so they said sleeve gastrectomy is an acceptable procedure if you're willing to follow those patients up. If those patients will commit to lifelong endoscopic surveillance, okay. The ABS position statement on this also read, so if you have patients with conclusive and objective evidence of preoperative GERD, LA grade C or D esophagitis, they need a bypass. And then it's advisable if they have a sleeve that they're screened for Barrett's afterwards at 3 years, and then again every 5 years afterwards would be reasonable. The other thing that I think has been really interesting is if you look at the bariatric forums that have our sleeve and our bypass patients in it, this is what we're hearing. These are things that I looked up on the forums that people are talking about. And one person said, I decided to have the gastric bypass due to the amount of people on the forums that are saying that they're having horrible reflux after sleeve. And then one patient actually told me last month, I feel so bad I lied about my reflux because that's what they told me to do on the forums if I wanted a sleeve. So I lied about it, and now I feel bad because she's getting a bypass now. In my practice, it used to be about 80% sleeve, and that's changed. Now it's about 40% sleeve and 60% bypass. But it's also 60% primary cases and now 40% revision. So what are you gonna do? Are you gonna routinely survey people for the rest of their lives for Barrett's? What's the attrition rate in people? How many people never actually follow up in your practice? I looked at my attrition rate, our practice attrition rate in 2020. In 417 primary cases we did, at 1 month we had a 91% follow-up rate. At 1 year we had only 45%. How many people are we missing? How many people in the databases are we missing? This is an interesting study of esophageal cancer after gastric sleeve. They had 3 men who had esophageal cancer. All were last to follow up at 3 to 5 months. So what are you gonna do? Change your informed consent to let sleep patients know that the rate of reflux is 20% or greater, that the rate of Barrett's esophagus is 9% or higher, that the conversion rate is up to 10%, we think, maybe higher, and it's increasing? Or are you gonna let them stay on PPIs forever knowing that it's its own long-term risk? And currently there are over 100+ lawsuits on the use of PPIs. Or are you gonna do the gold standard, gastric bypass for moderate reflux in the obese patient? Better weight loss, better resolution of reflux, and it's the one best surgery. So don't wait for a second revisional surgery to fix the problem, do it the first time. Thank you.